We typically see it. Never forget your outliers. Outliers exist, but typically 35 and younger. And it's usually 35 and younger because they tend to have stronger soft tissue fascia. It's just being younger, your muscles are bigger, stronger, all of that, and so you have stronger fascial structures. If you have an increased muscle, somebody admit, Andrea, awesome. If they have increased muscle, okay, all right. If they have an increased, muscle bulk, obviously just creating more perfusion issues. We see it typically in high energy injuries. So if you have a high energy injury, ideally, a fracture underneath will show you it's a high energy injury, but it does not have to be that as well. Please know, but that's typically where we see it. And we see a greater incidence, 10 times more likely to happen in male versus female. Usually it's more activity related. They will take higher risk kind of activity, right? We see this in high energy fractures. It's usually the tibia. So any kind of tibial fracture at all, your little ears should perk up and say, let me be on the lookout now. And it also can occur in thermal injuries, lithotomy positioning, constricting casts, IV infiltration, nephrotic syndrome, rhabdomyolysis, and infection. So it really is a very broad spectrum of things that all of a sudden this can kind of appear. And that's probably why I get a lot of consults for it, because it's really hard to know when these things could occur, because you don't want to forget the outliers. So our pathophysiology in this is it's basically very, very simple. It's very simple. We have tightening of things. We have the need for blood flow to get to an area from injury or any of the aforementioned from before, right? We need blood flow to get to that area, and so more flow does get there, too much, and now it starts to constrict everything off. So basically, we're looking at the muscles, right? Muscles, nerves, arteries, and veins. Those are big things that we find in our compartments. They're all surrounded by this deep, thick connective tissue called fascia. It's the really, really thick white stuff that you see if you're a meat eater, right? Especially steak, and you're chewing on something, that's probably fascia. But that's what that is. And you see it's very, very hard to kind of break down, and it certainly doesn't have any elastic component to it. So either we have swelling that's happening because there was trauma to that area, or reperfusion is another one. Whenever you have decreased blood flow and then an increase in blood flow, you'll get this reperfusion, and now all of a sudden we have more things going into this compartment. We have the initial decrease in perfusion. You get swelling. It's just physics, really. You decrease in perfusion, and now all of a sudden you have an area that's just getting, further and further and further into greater pressures. And the more pressure that's there, the more it's going to constrict on the soft structures. The structures we're really worried about are arteries, veins, and nerves, right? We need to have perfusion, and all of that pressure, those things will just kind of collapse underneath it. Not so great. So when we look at this and say, okay, we have some sort of injury, we have some sort of reperfusion, we have something going on, what are we going to see clinically? We know now, okay, these are feelers putting out, okay, this might be a patient that is at risk for this. What am I looking for now as a clinician? And what you're looking for, first sign, is pain, right? Pain is going to be your first sign. The problem with pain is we don't have pain all the time, right? You have an injury, you're going to have pain. So that's the hard part about it, is your initial, first and most occurring symptom is going to be pain. So, okay, go with the pain. The second thing we're going to have is paresthesia. Now, this is kind of that next phase of what happens. You start to get that tingling. You're listening for your patient to tell you that numbness, a little tingling, it just doesn't feel right. I got a lot of pain and now I have numbness, tingling. Now your feelers are going up even more. So we have pallor, we have paralysis, we have pulsinosis. You learned in school about the 5 Ps. Somewhere I learned there were 6 Ps. I think there's somebody even quoted 7 Ps at some point. But at the end of the day, this researcher, von Kudin, I thought his was actually the best way to say it. There's 5 Ps, pain, 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 and pain. Because that's really what you're looking for. Once you start to get the paresthesias, now you're really worried about it. But pain is your biggest thing that you're like, this is somebody that you're very concerned about why they have such a high level of pain. Once we get to those other things, it becomes very problematic then. And now we're talking about irreversible stuff. So there are a lot of ways to look at what are we doing with our symptoms. And we want to know what's reliable and what's not reliable. So palpable swelling is going to occur 50% of the time when it comes to an injury, right? But when it comes to acute compartment syndrome. But it is only 24% sensitive, 55% specific for acute compartment syndrome. So not a great way to kind of say, yeah, this is it or this is not it. People have also tried a pulse ox, right? Because now if we have decreased perfusion, we have a tissue that's hypoxic, maybe we can tell via pulse ox. No, don't do it. Your triple threat is going to be your pain with your passive stretch. So remember, a passive stretch is you telling that patient to relax and you moving the joint. When you move the joint, you try to get them to relax, you are acting as the muscle. Muscle's not going to want to do that if it's severely compressed, right? Technically, if there's a fracture under there, you're really not moving too much of that fracture. So it's really the muscle within the compartment that you're moving. It's not going to like it if you have acute compartment syndrome. So pain with a passive stretch. Paresthesia, as I said, they're telling you numbness and tingling, feels weird, then you got to be concerned. And then obviously pain at rest. If you have those 3, the sensitivity is 93 and 98%. Okay, that's when you're saying, okay, hey doc, got a surprise for you. There are a lot of research has been done to see, can we do this in other ways? Can we figure out acute compartment syndrome in other ways? Serum lactate, just hasn't been shown to be really good enough to say, yes, this is a definitive marker of acute compartment syndrome. Creatine kinase, which as we know is released with muscle breakdown. Maybe if somebody has rhabdo, we can look at CK levels. It's there, but it can't tell you confirmatory or not. We could do serum troponins again when muscle's under stress. Does that rise? The myoglobinuria, hyperkalemia, all things we see with muscle breakdown, but we can't necessarily say, yes, this goes exactly with compartment syndrome. So what we do is we say, okay, we have our clinical exam. We know who our players are. We have a mechanism of injury. We have some sort of something that's going on. We are seeing now symptom-wise our patients complaining of these things. We're going to now say, how are we going to actually diagnose this? And the diagnosis is clinical. It is 100% clinical. You do not need anything else to actually take somebody to the OR. You can say, clinically, this is acute compartment syndrome. What we do is we say, okay, we have a patient comes in, they have an injury, say a tibial fracture. And we say, okay, we are going to now monitor this patient. And so we look at everything and we say, we need to do compartment checks. And I'm going to get into how we're going to do that. But we're going to do compartment checks, and we do them every 4 hours. So we do them on presentation. Now, in an acute injury, if somebody, say, brought in immediately from the injury, we're going to do what we need to do and do a compartment check right there at the very beginning, and then every 4 hours after that. Sometimes we are not lucky enough to see somebody right after injury. A lot of times we will see somebody, and again, this is still acute compartment syndrome, but the second, highest group that we see when it comes to acute compartment syndrome is people that are found down. A lot of drug overdose, and they're found down. Or simply somebody just fell. Older person has fallen. Now remember, the older people have a little less muscle bulk, all that stuff, so we don't see it quite as much in them. But when we see people that are found down, and they're down for, say, 12 hours, 24 hours, we're not sure, then it gets really tough. We're still going to do our compartment checks every 4 hours, but we're getting further and further outside of that window. So we do compartment checks for somebody, usually for the first 48 hours after injury. Okay, that's when it's going to develop, because as we know, right, you guys know, swelling occurs for about 2 days after an injury. So we do compartment checks every 4 hours, and we need a proper handoff. When I say that, I mean that my shift's ending. So what I need to do is I need to grab you and say, hey, you're coming on. We're going to go do this last compartment check together. So you see what I see. When you know what I documented, you're going to know what I'm feeling to know if it is worsening or not. Take the next person with you and do a compartment check. That's the best way to do it. You're going to potentially use some sort of measuring device. Now, the measuring device you'll use outside of your own hands. We'll go over the compartment syndrome actual exam, but there are these catheters that you can use that you insert inside the actual compartment. It's painful, right? It requires skill on your level. It requires you to find that piece of equipment. And that usually is your hardest part, because the ED has it, maybe. Does anyone know where it is? Probably not, right? So these are things you don't want to rely on. You want to rely on what your brain and your hands can do. But this particular device can measure compartments. And that's good, because when we know what the compartment pressure is, it's going to give us a good indication of how much pressure is this area under. So when we do our compartment checks, we're looking at, depending on the body part it is, but I'm going to go over the most common one, which, like I said, is our lower leg one. You're looking at 4 different compartments. And I like these 2 different diagrams because it shows you the different compartments, right? So this is, if I'm laying down here, right, this is my right leg, this is a left leg, if you cut it and you're looking at it, right? So you have your lateral component, and you can feel it all the way on the outside, right? You have your anterior component, and then you have your deep posterior and superficial posterior. And when you look, you can see here, we'll go into the fasciotomy points, but 2 fasciotomy points hits the compartments on both sides. So what you are doing as you're doing your compartment check is you are feeling around to both. And you kind of, I have to say that the deep posterior, you don't get quite as well, because it only has just that little tiny bit. You can see it over here. It's just a little tiny bit that it comes across. But as long as you're following the bony structures, you should be able to feel all 4 compartments, okay? And then you're feeling the entire area. And what are you feeling for? You're feeling for it to be tense, for it not to have any kind of compression at all. It's gonna feel pretty darn solid. That's no bueno. We don't like that. So like I said, the intercompartmental monitoring requires knowledge and skill. It's not often done initially because we don't see it. It's usually used on our way to the OR or in the OR before we cut open that compartment, because you don't need it for your diagnosis. it's usually to confirm the diagnosis right before you get a scalpel in your hand. And the other difficult part is different compartments have different pressures. Great, thanks, Deb, appreciate that, right? I can't help it, right? In the lower leg, the compartments are about the actual normal is like, I don't know, 10, 12 or so. And so 30 would be considered your diagnostic number, right? That's very different from the compartments of your glutes, which we've seen, gluteal compartment syndrome, right? It's very different in the forearm. It's different in the hand. Anywhere there is muscle with fascia, you could possibly get compartment syndrome. We see it in the leg or in the anterior thigh, but not as much. Lots of room to swell. There's a ton of room to swell. We're looking at areas that don't have that much room to swell. Forearm, lower leg, hands are big ones, and glutes. But they all have different normal compartment pressures. So it makes it very challenging. All right. Now, I'm not one to kind of show videos like this very much, and it's very cheesy. I'm sorry about that. It's very cheesy, but it's actually very good. So we'll watch it just because it is good. Sorry about that. But I thought it was really a nice little overview. You could see, like, I don't know about you, but I got bored about halfway through her explaining how to set up the whole striker thing, right? Full disclosure, I've never strikered anyone. It just, the diagnosis can be done clinically. You don't need to do it. My colleagues have. I haven't done it. All right, so our bedside monitoring, as I said, serial exams. You must have access to the compartments to feel. Now remember, I said earlier, one of the big mechanisms is a tibial, usually like a nice tib fib fracture, right? So if there's a fracture, people like me in ortho are gonna be, let's reduce it, let's put a splint on it. Need to do it. Well, how are you gonna feel things if I have a big old splint on it? Well, either I'm creating windows for you to do it. So we cut out little, honestly, little windows and that you can actually palpate, or we will just resplint it every 4 hours if we need to, if we're that concerned about it. I don't care. Call me as many times as you need to resplint it. But we need to be able to have access to those compartments. Remember, the other thing we're going to need to do is to do our stretching. We need to do our passive stretching. Can't do that if you have a splint. Right? Super important to remember in the court of law, because I practice very much CYA medicine. And so if there is a splint on there that hasn't been taken off or broken or something, then how can you say you possibly did it if there's a splint on it, right? So it's important to remember those things, right? We have to have access to the foot and the toes to do our passive stretching. Again, go with a colleague so you can understand where they are when the last, 12 hours of the shift to the next one. And then you have to document. Document. CYA, right? Document. You have to just, it doesn't matter. You don't have to be so proficient in what the language is. Just what do you see, what do you feel, and where? Don't get hung up on, do I have to have the actual verbiage? What do you see? The first thing you see when you walk into a room is what is that patient doing? If that patient is on their phone, they do not have compartment syndrome. I guarantee you that. They do not have compartment. And you will see this, right? If they are relaxed, if they are watching TV, if they're talking to someone, if there are not tears coming out of their eyes, they probably do not have compartment syndrome. It's that painful, right? Unless you're seeing it well after where they don't feel anything, and then obviously that's a problem there, right? But it's so important because I get consults on these, rule out compartment syndrome in the middle of the night, and I go there, and the patient's sleeping. You don't have compartment syndrome if you're sleeping, right? It is what it is. So document how that patient looks when you walk in that room, because that stands up huge in a court of law. Then what do you feel? With each compartment, document each compartment. Is it soft? Is it compressible? Is it painful to touch? Then you document what your passive stretch is. Then you document, are they warm? Are they well perfused? Is there a pulse? DP pulse, PT pulse. We want to always kind of, lay it all out in our compartment. That's a compartment syndrome or a compartment check note. We're looking for subtle changes from every 4 hours. It's not going to hit quite so hard. If it didn't hit right away, we're watching for these changes to occur. Ask the patient. I say this so many times. Please talk to your patient. Talk to your patient. Does this feel worse than when I saw you 4 hours ago? They will tell you. If it does, cool. All right. If it doesn't, great. If it feels the same, but you need to know, does it feel worse? You're doing the vitals. Sometimes, right? Sometimes these tib fractures come with, fractures of all other things because they were in a big motor vehicle accident, right? They might be intubated and sedated. That doesn't mean they don't have compartment syndrome. So how are we doing our check on somebody like that? Well, we're watching the vitals, right? Move their foot around. If they don't like it, you'll see things start to increase on the monitors, right? You will see, you can note those things. Sometimes people will actually try to resist it a little bit if they don't like it. Again, sometimes these things are hard because there is there's a fracture underneath, and fractures hurt. So that sometimes it just gets really, really hard to see. So you gotta look at everything. You gotta look at everything. If you are doing compartment checks and you start to notice that your ears are perking up a little bit, your spidey sense is going off, start to pre-op that patient. Doesn't hurt. Start to pre-op the patient. So start getting labs, start getting things, call anesthesia, see what their thoughts are. Give fluids, antibiotics if you think there's any kind of tissue necrosis that's gonna start to happen. And now you have to start to call the surgical team in. I don't know about you, but at 2 o'clock in the morning, in order to get somebody to the OR, as soon as we, kind of sound the horn, I don't know, 2 hours later, maybe we actually start. So you got to start that process. Notice that we haven't really reached out to a doc yet until that point. This is all PA driven, right? It's the clinician. You need to talk to your nurses about this as well. You will be there. Nurses, the bedside nurse, it's really important that they're on board as well. Take the time to educate them what they should be looking for, when they should be calling you, if it need be in between those 4 hours. This is a team approach before that surgeon even gets there. And I can't stress enough how important it is because it's a clinical diagnosis that as PAs, we are on top of it. And you'd rather be wrong than miss it. And so you want to really be on top of the game on everything that you're doing before we're calling everybody in to the OR. So these are all the things that we just talked about. How you want to document, because documentation is key, absolutely key. And then thing that's important, and I say this so much, I say this to everyone that is in front of me at all with any kind of writing and documentation about an assessment. At this time, say that with everything in life. At at this time, this is what it is. Because if an hour from now it's totally different, I don't want to be held liable for it. When I checked, this is what it looked like. At this time, there is no concern for compartment syndrome. Or there is a concern for it. The next check will be whenever, or compartment checks will be done. So why is this super important? Because we don't have much time. You know, we talk about the compartment checks being every 4 hours, but if you look at our timeline, it's even shorter than that, right? So 1/3 of the cases of compartment syndrome have muscle necrosis within 3 hours. 3 hours, it's not a long time. It is reversible if we can do that decompression within 4 hours. It's irreversible if it's delayed longer than 12 hours. So that muscle just kind of goes away, no bueno. Also, the other things, the arteries, veins, and nerves now also go with that. The earlier the fasciotomy, the better the outcome. We're going to have decreased injury the earlier we do it rather than later. Once you have nerve deficit, it rarely comes back. That's a lot. That's a lot to think about. Once that's gone, it rarely comes back. After 6 hours, it's not coming back. 6 hours. So once we have acute compartment syndrome, we have very little time to get everything back to where it needs to be. Reach out to that surgical team. Now, I'm in ortho. We do this a lot because a lot of times there's a fracture, but you can have a vascular injury that can also cause compartment syndrome. Vascular needs to be taken to the OR. If they're in the ED and there's no, you know, it's always a problem, right? They reach out, sometimes they reach out to ortho. A lot of times they reach out to ortho. Hey, we got this. Yeah, but there's no fracture. I don't know. There's no injury. What do you want me to do? I'm ortho. Call vascular. Right? But at the end of the day, I still drag my butt down to the ED to check that out, because if it really is compartment syndrome, I know what it looks like, and I'm telling them, get them here right away. They need to do this. At the end of the day, I can also, if they can't get a hold of them, we can still take them to the OR and do a fasciotomy if need be. But you want to take care of that patient and figure out who's the right team to take care of that patient. If you need to see them first, it is what it is. Remove any external dressings. If there's anything on there, make sure you take it off. Allow it to swell. It needs to swell. Elevate. So simple, right? Elevate. Elevate reduces swelling. Fractures should be reduced. That will help put everything in better anatomical position. And you always want to treat the pain with PO meds. Do not block these people. A lot of times, depending on where you are, if there's a fracture or whatnot, maybe we can do a regional block, get them out of pain. No, bad, because then they can't feel anything. That's not good, right? Treat them with PO meds. Whenever you're seeing any of this stuff, speak up. You guys are the ones that are going to know about it. You can sound the alarms. So, all right, what are we going to do? We're going to do a fasciotomy. If we see this, we need to relieve the compartment pressure. How do we do that? Slice it open. Simple as that. Open it up. And so what we do is we go into those points from that diagram I showed you before. And we will just open it up, allow it. It immediately reduces the pressure. If you've ever seen it, it's like, poof, comes right out, and problem solved, right? Again, looking at these compartment pressures, that differential pressure, their perfusion pressure. Again, hard to know if this is really going to be the thing that's going to make or break it, right? Again, it can help you in your insurance documentation when you're in the OR. Hey, this is why we did it. But you don't necessarily have to do this to say this is compartment pressure and a fasciotomy should be done right now versus no, it's just not. It's at 29, it's not 30. Right? We do the fasciotomy in this kind of way, opening it up. Again, right where we tested those things, we just open that up, allow it to stay open. Now, when we allow it to stay open, it's kind of weird, right? You have these two open kind of cavities, but a lot of times what we'll do is we will throw like a wound vac on them just to keep it open and keep that area kind of sealed off. So we put a wound vac on it. Sometimes if there was tissue necrosis, infection or whatnot, they can do the wound vac that irrigates it, that has that kind of slow irrigation. Sometimes we can do things that are like a Jacob's ladder where we have two sterile elastics that it's kind of like a corset and we just tighten every couple of days to start to close it naturally. Or sometimes we take it back and close it, make it a little bit, sometimes we'll close, this end and the top end, and then we'll get a little closer, a little closer, a little closer. But we're opening that up. What we've also started to do with other ones, and I don't have any pictures of it, but it's really cool, is there's a lot of little slits. They do like 1 centimeter slits, and it almost looks like it's perforated along that fascial area, if they can do that. And that has a little bit of a nicer cosmetic look afterwards, but this is something that's, every surgeon knows how to do a fasciotomy. This is a terrible flow chart that you can't see about all the things that you can look for. Oh, look, see, we have 6 P's over here. But looking at, okay, is the patient conscious? Are they not conscious? If they do this, measure this, all of these things. It's a nice little flow chart for you guys to see. What are the outcomes? Early intervention is key, but you can't do it too early, right? You don't want to do a fasciotomy if you don't really need to do a fasciotomy, because that's not great, right? But the earlier you do it, the better. Why? Because if you look at a delayed take to the OR comes with a 54% complication rate. More than half the time there's going to be complications if you wait too long. If you do it early, 4.5% complication rate. So much better. So much better. So you do not want to delay on this at all. The complications you're going to get, additional surgeries, because once you open it up, a lot of times there's going to be surgery to close that. A delayed wound closure, skin grafting, cosmetic problems, pain and nerve injury, and permanent muscle weakness. All things that you do not want your patient to have. You want to restore function as best as possible. And that all leads to an increased cost of care, which I'm always somebody that I like the healthcare dollars in our pockets versus the insurance companies, right? So you don't want to continue to have this patient undergo a lot of medical bills. You don't want your hospital to have a lot of medical bills, all of that stuff. So your threshold to go early is a whole lot bigger than, let's just wait till the next time. I don't know, let me call my doc. I don't know. It's better to get everything going in the right direction and have to pull back than to wait and then deal with these complications later. And that's that. What questions do you have? Yes.
Have you guys used the Myo one? It's like you like kind of leave the probe in. It's kind of like a striker. We did them like 2 weeks ago, since I work in trauma surgeries. So a lot of our patients are intubated.
Yep.
For that kind of population, that's not going to tell you. So you can just kind of find your landmarks, put it in, and then it gives you a reading.
Yeah. Yeah, we just got, I learned about that this time last year, and we just got it at our hospital, I don't know, maybe a month or 2 ago. So I think only 1 or 2 of us have used it at this point. It is a good tool. It's better than the, all the setup that you need to do with the striker one, but it's all dependent if your hospital has it or not. I know that it's also a little on the costly side, which, depends on your hospital. Are they gonna, kind of foot it or not?
Yeah, I think we're figuring that out now.
Yeah.
It probably will go out of vogue.
Yeah, we'll see. But yeah, I've heard about it, and it could be a good tool.
After you do the fasciotomy, you say you leave it open,
Mhm.
like how long?
You leave it open for typically a couple of days. You do wound vac change. You wait till the patient's a little more stable, till everything is kind of, we usually take it back every 3 days or so. Sometimes we'll do a washout. Sometimes these are our 4 washouts purposes, and then we start to close it when the skin and the compartment feels like the swelling has gone down.
So you should be able to just use primary closure.
You can, we've done it, yep, we do a primary closure.
How often is it missed?
It's, once they're in the hospital with clinicians, it's not missed that often. It's usually that it's just they come to us and it's too late. Like they've been found out and it's been 24 hours and they just, they just can't, there's nothing we can do. They're already kind of numb or have the neurovascular damage.
Mm-hmm.
So that kind of stinks. It stinks when we have that. Yeah.
How often do you see it?
Not that often. I do work in ortho trauma, but not as much. I cover a lot of things within ortho, and I don't cover a ton of ortho trauma. But even over there, we're the big trauma center for Southern Connecticut, and I would say we probably maybe once a month have it.
That other value, the diastolic pressure minus, if it's still below, would you still do a fasciotomy?
You can. If clinically it looks like you need to do a fasciotomy, you do it. Yeah. That's why I say, numbers are great, but not really. Because if it looks like it needs to go, if they have pain and they have paresthesias and their number's 29 or 28, you're still taking them. You just don't know what their norm is. And so it's a guiding kind of thing, but it's not something that just, yeah.
Does the presence of compartment syndrome and need for fasciotomy change the management of an underlying tibial fracture?
No, because we can always fix that fracture. Usually what we'll do is put them in an X fix if we need to. We'll deal with the fracture later. We can always fix things. I have a story about one time in the middle of the night, closer to the morning time, but in the middle of the night, I got a call to rule out compartment syndrome in a maybe 20-year-old Yale student that came in. And I went down there and so I see the patient and I'm like, well, is there a fracture? Is there a fracture? What's wrong with the bones? Nothing wrong with the bones. There's no fracture. And I said, was there an injury? No. Doesn't sound like me, but I'm going to go down and see. So I go down and talk to the patient. I see the patient. I approach the patient. The patient is diaphoretic and a little shaky. I'm like, ooh, you don't see that, right? So spidey sense goes up. I don't see that typically with my patients. He's literally sweating and a little like, okay, how you feeling? My leg hurts. Tell me more. I don't know, it just hurts back here in my calf. Okay, that's weird. And I have no choice but to kind of touch right away. Just touching, I'm like, kind of feels hard, not great. When did this start? Well, I don't know, it just started yesterday maybe. Okay, tell me more. Well, it started at the back of my knee, and now it's kind of moved down. I don't know what you got, kid, but it ain't compartment syndrome, but you got something, so tell me more. I'm interested. Now I'm curious. And he was like, I don't know. That's what it was, and now I don't feel good. Labs come back, and his white count's 46. I'm like, oh, God, what's happening with you, kid? And I started talking to him about the fact that I said, I don't know, they call me for compartment syndrome. That's when the compartments get really hard or whatnot. It's usually happening with an injury or something. There's something going on. That's not what's happening with you right now for me orthopedically, but you're gonna need surgery because this isn't good. I know something's happening in there. clearly you have an infection, unclear why you have an infection, but something's, so this is what you need to do. And as I was doing it, my buddy who was the gen surge attending, who was covering SICU that night, comes to see the patient. And so he and I are talking to the patient and he's like, yeah, Deb's right, it's not this, but you do have something. We're gonna send you to surgery. We're gonna go for a washout right now. And come to find out, the kid had necrotizing fasciitis. And how it happened was he had a Baker cyst that I wanna say had strep. It was strep that was in there. 3 weeks prior, he called the Yale Health, telehealth. They didn't do a swab, they just assumed, yeah, this is probably what you got. I think they gave him antibiotics, but it was, he had an infection. And so that strep somehow went into, bloodstream, settled into like the posterior aspect, right? He had a Baker cyst that was a septic one. It ruptured and went down his leg. Kind of cool, right? Cool story. I should have done a case report on it. I didn't know. But that's the kind of stuff that somebody calls you about something, go see the patient. Just go see the patient. And it's so much fun to say, yeah, it's not me, right? The satisfaction of that is fantastic. So and I like to hear these kind of stories because this is the kind of stuff, this is why we're here. That's why I like ortho, because it always comes with a good story. But never take the opportunity to not see a patient and just weigh in if somebody's calling for help. Consults suck because you have patient loads and this and that. It's usually at the worst time, usually 5 minutes before you shift end or before you stop taking consults. But people need us and they call us because they need us.
Not really a question, but, or I guess maybe for everybody, has anybody been called on abdominal compartment syndrome? We actually had ortho get called to just from critical care to assess a patient's limbs because they were super tachycardic and they were having all these issues, and they, I think, were just in, post extremis. But ortho called us from an emergency surgery and was like, hey, their belly's actually, it's not really their thigh, but their belly's pretty tense.
Yeah.
And the numbers are a little different, but that 30 in abdominal compartment syndrome is a 20. So if you put a Foley catheter in, you get a bladder pressure. Hey, this guy has, so ortho is also standing there being like, not me, but
yes, we do that.
hey, also you should look at this belly, which is a little rare on my side for ortho, but
Yeah.
but it reminded me of that. So we do a fair amount of abdominal releases for abdominal compartment syndrome. And it's always like the post-op patient, or it's the patient that got in an accident, maybe they have a bucket handle injury or something from the seatbelt sign. And it's the same type of thing. It's like,
Yeah.
really releases. So
Yeah.
something to keep in, yes, it's all your limbs, and there's some limbs that are rare, like more rare than others for compartment syndrome, but the belly, your pancreatitis patients, super common.
Yeah. Yeah. And good for ortho to be
Yeah.
like, hey, we checked out something other than an
It was like a
extremity.
young,
Very good.
like just had a PA school kid, so it was like very, very sweet, very cute. So.
Yeah. Anything else? Yeah.
Thank you so much, Deb.
Yeah, you're welcome.